Discussion on ECG monitoring in ICU. Following are the usual goals of ECG monitoring in the intensive care unit: heart rate and basic rhythm determination, diagnosis of complex arrhythmias, detection of ischemia, and prolonged QT interval. Advanced monitoring facilities may be used for following features which are yet to be well established: computerized ST-segment analysis, computerized arrhythmia analysis, computerized QT-interval monitoring. Over the past few decades, since the initiation of ECG monitoring in the 1960s, several improvements have occurred. They include improved noise reduction strategies, multi-lead monitoring, and derived 12-lead ECGs. Cardiac arrhythmia monitoring is needed for all patients at significant risk of immediate life-threatening arrhythmia, which include post-cardiac arrest, early phase of acute coronary syndrome, post-cardiac surgery, and after anesthesia. Battery-operated monitor defibrillators are useful while transporting such patients. Personnel watching the monitor in the ICU should have skill in ECG interpretation and defibrillation. In the setting of an acute myocardial infarction, ST-segment ischemia monitoring is useful to assess the patency of culprit artery after thrombolysis, abrupt reocclusion after primary angioplasty, and to detect ongoing ischemia or infarct extension. ST-segment monitoring is not useful in left bundle branch block, ventricular paced rhythm, arrhythmias that obscure the ST segment, and in patients who are agitated. Following steps are useful in improving the quality of ischemia monitoring. ST segment should be evaluated only in supine position. Careful skin preparation should be done to improve the lead contact. Consistent lead placement is needed for comparisons. Ideally, the electrode positions have to be marked with a skin marking pencil. ST alarm parameters have to be set based on the patient's baseline ST level. QT interval monitoring is useful in patients on antiarrhythmic drugs known to cause toss at the points. It is also useful in the overdose of a potentially proarrhythmic agent, patients with new onset bradyarrhythmias, and in those with severe hypokalemia or hypomagnesemia. Limb electrodes are placed on torso to reduce muscle artifact during limb movements and also to avoid tethering of the patient. Right arm and left arm electrodes are placed on the corresponding infraclavicular fossa. Left leg electrode is placed below the rib cage on the left side of the abdomen. Right leg electrode can be placed anywhere on the right side of the abdomen. Some monitors, especially defibrillator monitors, have only 3 cables. 2 of them are active and one is a ground electrode. These are usually used as modified limb lead monitors, typically in lead 2 configuration with leads attached to the torso near the limb. Modified chest leads MCL1 to MCL6 configurations can be used to monitor chest leads with 2 electrode cables. For MCL1, the negative pole is kept in the left infraclavicular fossa and positive pole in the fourth right intercostal space close to sternum in V1 position. For other MCL leads, the positive pole is shifted to the corresponding chest lead positions. Approximate position of electrodes for MCL1 monitoring lead. The combination for lead 1 can be used in reverse manner for MCL. Right arm electrode is kept in left infraclavicular fossa and left arm electrode in V1 position. Unlike the usual chest leads which are unipolar, MCL1 is bipolar. If electrodes for lead 2 are being used, left arm electrode can be placed in left infraclavicular fossa and left leg electrode in V1 position. Using multiple limb leads is possible only in monitors with 4 electrode cables, 3 active and 1 ground. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video.